Well, first of all, thank you very much for the invitation. It's a great pleasure to be here. I actually love to teach. I really get a kick out of teaching. I don't know why, to be honest. I don't know why. It's something to do with my urge to serve. I'm a natural servant, you know. Some people are born to be a lord, be a king, be a prince. I'm born to be a servant. Um, so and it fulfills that that desire in me. I really, when I see someone doing well under my teaching, I get such a kick out of it. And it's not just theory, it's also in the operating theater. When I take young people through cases and they learn and they progress, I really, really enjoy doing that. More so than doing it myself. It's interesting because it increases your impact exponentially. If you think about how many operations can one surgeon do in a lifetime, assuming that person is a workaholic and just does nothing else. Well, if you take that number and compare it to the number of people that die every year of heart disease, you see that it's nothing. The impact is tiny. But if you teach, the impact increases exponentially because all those people will go in different directions and operate different patients. And each patient they operate, there is an element of you in it if you've taught that person. There are also elements of other people in it. Let's say you learn your operation from when you go through training. By the time you finished, let's say you have worked under, say, 10 consultants. I say 10 is a figure pulled out of a hat. I mean, it could be any. It could be less. It could be more. Doesn't matter. And then at the end of the day, you pick things up from each of your bosses. And in the end, you form your own technique. At the end of the day, we each operate our own way. It's very personalized. It's tailor-made to what works in our hands. But there's a percentage of all of those people in you, even if it's negative. Even if you have seen something you've disliked and you've decided you're never going to do that, that's still some element of that person in you. So if you do that, then your contribution just goes off the chart. It just goes up exponentially. And that really gives me a kick, really does. And it's part of the reason why I liked this invitation, part of the reason I wrote that book. It's all part of the same philosophy. Now, let's get down to pathophysiology. Why? Why did I get into this? What's the big deal about this? Well, it's something I noticed in medical school, that disease, when you learn disease falls into two groups, acquired and congenital, in a very big sense. And acquired essentially has three combinations. It's inflammation, vascular, and neoplasia combined in different proportions in different directions, but that's essentially, you take any acquired disease, it's various permutations of those three processes: inflammation, vascular, neoplasia. So what you're dealing with in acquired any disease, not just heart disease, is that you are essentially dealing with a person in whom the processes are normal, but they have become inefficient. That's what acquired disease of any sort does. So the basic principles are the ones of normality. So you have a normal blood vessel, it becomes diseased and it becomes narrowed. You have a normal joint and it becomes, through wear and tear, becomes arthritic, less efficient, more painful. For example, you have a normal stomach, normal intestines. Through years of bad eating and smoking and alcohol, you develop ulcers. But the basic structure and the basic processes are there. They just become inefficient. They become painful. They give you problems that way. So by the same token, when you treat them, what acquired disease, you are slowing down that deteriorating process. But the process is the same. You just delay it. If you have narrowed blood vessels, atherosclerotic blood vessels, what do? You could put a stent in them, open them up, but that doesn't cure the disease. It slows it down. The atherosclerotic process grows through the stent and causes the same thing again, but you've delayed it. Or you write it off and you put a bypass graft on top of it. Again, you're delaying it. The disease process is in place and it's spreading. You just pushed it back. The outcome, you've pushed it back 10, 15, 20 years. The same applies at joint replacement. The same applies at valve replacement. You're delaying things. The process is the same. If you leave the acquired disease aside and you go into congenital, the rules change completely. The processes are different. And I'm not talking just cardiac. I'm talking generically. Any condition, the physiology changes. I happen to know about the heart, but if you think of, let's say, some musculoskeletal congenital anomaly, let's say someone with abnormal hip joints, born with dystrophy of the hip joints, the entire mechanics are different. And it affects other joints. So they get early atherosclerosis at nearby joints because the movements are affected. The whole process is different. The lines of stress are different. You get someone with a cleft palate. The entire swallowing mechanism is different. The entire speech mechanism is different. And when you correct them, unlike when you deal with acquired disease, when you delay the process, with congenital disease, you alter the process. You change the process. So that's a completely different approach, completely different philosophy. We're not delaying things. We are changing things. Now, we don't always change it to a cure. We change it to something less bad, which is a different process. And you can apply that to, let's say we use the example of an abnormal hip. Let's say you do some osteotomies and you change the angle of that hip to make it work better. But by doing that, you cause other problems because the muscles are attached in a way to that abnormal hip that are not normal either. So you change the line of action of those and you end up in a different physiology that is completely different from normality. Going to the example of congenital heart disease, this is very extreme. When you take a congenital malformation that is very severe, let's take something very well-known, transposition of the great arteries, uncorrected. I mean, look at the physiology, it's just ridiculous. It doesn't resemble anything, So when we correct that, we are altering that. We're not delaying anything. We are changing the process. It's not a narrowed blood vessel with atherosclerosis that we need to dilate up or bypass. We are redirecting the flow of blood completely from one place to another. So that's something to keep in mind. It makes dealing with congenital malformations like a different game altogether. which you may think it's interesting or not. I mean, it's all a question of opinion. But one thing that is not a question of opinion is that it makes understanding them more difficult because they don't follow the normal rules. The normal physiology you know about doesn't apply suddenly. For example, we're all sitting here, we all have a systemic oxygen saturation of over 95%. It's probably not quite 100%, but it may even be 100%, but it's, let's say, 96, 97%. Now, if I were to decrease your oxygen saturation to, let's say, 90%, yeah, how would you feel? You would feel quite ill. You will not be happy. If you remember during the COVID crisis, what was the indication for going to hospital, for hospitalizing patients? Was saturation of 92%. If you remember, 92%, you go in hospital. 91, 90%, they put you on ICU, So how come we do a Norwood operation on a baby and we aim for a saturation of 80% and everyone's happy, including the baby? How does that work? Why is that so different? It's just the rules are different, completely different. Or when we do a GLEN, a superior cavopulmonary anastomosis, we're very happy with it, but the saturation doesn't come up. Let's say we go from a first stage of palliation of a univentricular heart with saturation of 80% that we were all punching our chest, being so happy about it, at 80%, and then we do a GLEN and it doesn't really change. It might go up to 83%, and we consider that a huge success. And where do these things come from? Where is the physiology? Where is the basis of it? Is there a technical problem?
No, I think someone accidentally unmuted.
Okay. So this is, it's just the rules are different. So, and it makes understanding them very difficult. I remember when I first got exposed to congenital heart disease, I was in my 4th year of medical school. And I chose then, I wanted to become a pediatric cardiac surgeon for one reason. Because one day I saw a boy, a young boy, an infant who was blue, went to theater and came out pink. And I said, that's what I'm going to do. This is me. That's the thing for me. And I never changed my mind. From that day onwards, the rest of my training was a question of navigating through my jobs, my progress, my education, my training, so that I reach that target, which took 15, 20 years. But that was the seed, that one boy. I could easily not have been there that day. I could have missed it and I would be a psychiatrist now or whatever. That boy, that blue boy, went to theater blue, came out pink, and I didn't understand a thing about any of it. The processes were all, that kid had pulmonary atresia, and you think, okay, well, what's the big deal about pulmonary atresia? So they need a pulmonary valve. No, they don't. They need more than that. And there's so many factors that come into it, and you can't even ask questions. Because people who answer you, they don't know where to begin. Because they don't know what is your base knowledge. Because I can talk about pulmonary atresia for 1 minute, or I can talk about it for 10 hours. Depending on how much detail you want to put in, what is the starting point of knowledge, you just don't know. So people just don't answer you. And when you're a medical student, much less. You don't even exist. So they just they just ignore you. So you just drown in ignorance. So you take the books and study them, and books take all these diseases and compartmentalize them. Like this is a chapter on ASD, that's a chapter on VSD, that's a chapter on, say, transposition of the great arteries. This is a chapter on hypoplasia of the left ventricle. And I studied them hard. But then you come across patients who don't fit into these chapters. There are patients who fall in between chapters. What do you do with the transposition of the great arteries who also has a VSD, who also has pulmonary stenosis, or the same patient also has one of the ventricles a bit small? These are all 4 different chapters into one. So what do? Or you take that and there's a VSD, and then that VSD could be very close to the aortic valve, or it could be very close to the pulmonary valve, or it could be not close to either one of them, or the VSD could be smaller or bigger. All of these things change the management completely. And as a medical student, I was getting my knickers seriously in a twist. And you can't even ask questions. These questions are so complex that in those days, I did not even know how to formulate them. And I say when I was a medical student, this continued well into my training. You know, I was even approaching being a senior registrar. I was still getting lost in these things. You know, and you ask your boss and they get angry at you for not knowing it. They say, you're a senior registrar, you should know this by now. And I'm thinking, well, I'm sorry, I don't. Can you explain it to me? You know, and some do and some don't. And one of the reasons I had a great time at Birmingham was because they did explain it to me. Mr. Barron never put me down because I did not know the answer to these things, for example. None of them. It was, I could actually ask those questions. The problem is there were millions of those questions. And then I realized something, that could be made simple. How to make that simple? Because it was insurmountable. The task was just, it was unmanageable. And then I looked at other people and I always wondered, how on earth did they learn all of this? The answer is they learned it over a very long time period. They learned it by just drowning like I was drowning. And, you know, 10 years, 15 years later, they come out and they are who they are. They become really good. They become solid. But they went through hell before they learned that. And I was just thinking, how can we avoid this? Is that necessary? Do we really have to suffer? And then gradually the penny dropped. And I reached the impression, not alone, I can't claim credit, I wasn't that clever, but through conversations with several top people who had figured it all out, but they were approaching retirement, you know. That's the thing. It takes so long to learn all of that. By the time you learn it, it's time to retire, you know. And I realized that it is a mistake to think in terms of malformations. If you think of malformations, you get drowned. It's like every time you have to reinvent the wheel. It's inefficient. So let's forget about the malformation specifically. Don't think ASD, don't think VSD, don't think tetralogy of Fallot, don't think transposition. Think in terms of processes, not malformations. The malformations become nothing more than examples of those processes. That way, no patient falls between anything. You take a patient and you think, okay, what is going on in this person? Don't think, He's got pulmonary atresia VSD. He's got transposition VSD, transposition intact. No, what's going on? What is it in this person that is killing him or her? What is that bad process? And how can you make that process better? So you work backwards. That process is this. How can I get rid of this process? Well, that process happens because there is this, that, and the other wrong with the heart. So if we approach those things and make those things right, those processes will go away or get better. That way you don't miss anything and you maintain a bird's eye view on what's going on in the patient. For example, let's take something extremely simple, an atrial septal defect. I don't think, let's say a 5-year-old with atrial septal defect. I don't think, okay, here's a 5-year-old with an ASD, I have to close it. No. Well, I do now because it's all a reflex, but it was more a case of this kid has started to run. At the age of 4 or 5, they started to run, and he can't keep up with his friends. Why is that? Well, that's because you look at the process, the heart is already on overdrive, especially the right ventricle, which deals with volume, and is on volume overload. So we need to get rid of that volume overload. Where does that volume overload come from? Oh, look, he's got a communication between the two atria. That's where it comes from. Okay, so let's get rid of that and it'll be fine. So I work backwards. Or something even more interesting, this wasn't actually very interesting, but let's say you take a patient like that who also has pulmonary stenosis. You know, if he's got pulmonary stenosis, that protects him against volume overload. So he's not going to be short of breath. He can run. But what might stop him is that these people with too much afterload, they're prone to arrhythmias. So he doesn't get short of breath, but he gets palpitations, you know? And you start to think of why. He doesn't get short of breath. It's not volume overload. What is it? Oh, look, his ventricle is hypertrophied. Why is that? Oh, there's an obstruction. But if there is an obstruction, how come he manages to maintain his output so well? Well, because he's got a volume that arrives from the other side and fills it nicely. All of these things, oh, okay, fine. You put all of that together, the processes together, and you explain it. Oh, yeah, he's got the ASD that allows blood this way. You have an obstruction at the pulmonary valve level that stops it. These two keep the patient well balanced. Okay, fine. So let's not touch the patient. The whole thing is balanced. Yeah. But if you don't touch the patient, then the patient develops hypertrophy of the right ventricle, which becomes fibrotic, which makes the patient prone to arrhythmias. Arrhythmias, what's going to get this patient? So you need to remove that obstruction to avoid the fibrosis. So you avoid future arrhythmias. But if you remove the obstruction, then you're going to put him in volume overload because his right ventricle will be flooded with all the flow from the left atrium. So if you're going to do that, you have to close his ASD as well. That's how I go about it, by working backwards, starting with processes. Now, there's a beauty in this. Although there are so many diagnoses in congenital heart disease, I think the figure is something around 200, you don't have to learn 200 diagnoses. The processes are 4 or 5, which are combined in different permutations in each patient. So if you learn those, it's volume overload, pressure overload, hypoxemia, ischemia. These are the 4 basic ones. If you don't have any one of these 4, you do not have congenital heart disease. You have a normal heart. Now, if you take other more complex things, there are combinations of these things. Tetralogy of Fallot, for example, is a combination of pressure overload of the right ventricle and hypoxemia. Simple as that. You have other examples of that. So every time you see someone with hypoxemia and right ventricular pressure overload, you can't just say, oh, he's got tetralogy of Fallot, because other conditions also have that. If you have transposition of the great arteries with pulmonary stenosis and a VSD, what have you got there? You've got hypoxemia, you have pressure overload, and you have volume overload. All of these things. So again, do you really want to take each diagnosis and memorize what it causes? You'll go nuts, and it will take you forever. Whereas if you understand the processes and you see how they come together, and then explain each one. This person has got hypoxemia because the pulmonary artery and the aorta go into the two separate circulations. Okay, fine. Well, why does he also have volume overload then? But because there's also a ventricular septal defect there that causes this. Oh, okay. But how come there isn't enough pulmonary blood flow there? Well, because there's also stenosis here, there, and whatever. Figure out the processes and then explain them with the actual malformation. That won't miss anything. That way, no patient falls between chapters because there are no chapters. Well, yeah, there are 4 chapters. Volume overload, pressure overload, hypoxemia, and ischemia. Fine. So you take someone with very complex malformation, and let's say univentricular heart, hypoplastic left heart syndrome. Okay, what is that? It's pressure overload plus hypoxemia plus volume overload of the right ventricle. But it's explained by different malformations. Let's say it's palliated. You go down the road, you end up with a Fontan circulation. What is a Fontan circulation? Fontan circulation is essentially pressure overload on the systemic veins. That's all it is. It's pressure, well, it's not all it is in the sense that there's one pump doing all the work, but it puts pressure, it's pressure overload, all the problems that you get from a Fontan circulation, and eventually it fails. I mean, failing Fontan circulation is a diagnosis in itself. It comes down to the fact that there's pressure overload of the systemic veins. Everything else are consequences. But if you want to learn each consequence individually and then explain it later because it's a Fontan, well, you get your knickers in a twist. So this is why I thought, let's just learn all those processes in detail, and that is pathophysiology. What does pathophysiology mean? Physiology is how things function, how everything functions in the body. Pathophysiology is how those things go wrong in disease. That's all it is. It's really part of physiology. Learn that and look at patients functionally. That way, when you're operating, you know the consequences of everything you do. Okay, if I do this particular maneuver, this will affect the physiology in such and such a way. So maybe I should do it to this point or that point, and no more, no less. All of these things you become aware of because you're looking at the whole thing in terms of processes, not specific diagnoses. And that, if you nail that, it facilitates your work tremendously. That means instead of spending 15 years to learn all of these things, you can learn it all in 3 months. You know, that was the reason why I thought, well, let's put all of these things in a book. I didn't even want to write that book. I was hoping someone with much more experience and much more knowledge than me would write it. I proposed it to one of the people that actually put these ideas in my head. It was Dr. Roger Mee, who's now retired. He was the chief at Melbourne Royal Children's Hospital in Melbourne. And he was well known for his profound understanding of the pathophysiology of congenital heart disease, amongst other things. He was also technically a great surgeon. And he's the one who told me, he was the first one who told me, he said, don't try and apply what you know from adults with normal hearts to these patients. These are not miniaturized versions of those adults. These are completely different processes. He's the one who first put that idea in my head. So I asked him why he would not write that book. And he laughed and he said, you should write it. You know, I mean, are you kidding me? He wasn't kidding. But anyway, 2 decades later, I wrote it. But that's the rationale behind it, is to make it easy. Otherwise, the field of congenital anything, not just heart disease, it's just unmanageable. There's so many processes going on. And when I see people who try and apply what they know from adults from what they know from acquired disease to congenital disease, they get their knickers in a twist. It's just the rules don't apply. I mean, I talk about the heart, but I've seen it in other areas. I've seen it in plastic surgery, plastic surgeons dealing with burns, which is an acquired condition, and those dealing with congenital facial malformations. It's like two different specialties. Same in orthopedics, same in abdominal surgery, same in urology, all of them. When they deal with congenital malformations, you have to go back to the drawing board. And in my experience, unless you understand processes, the task is very difficult, very, very difficult. And this is why I recommend people to go after understanding the pathophysiology and build it from there. Unfortunately, this is not what happens in training. In training, you do get taught pathophysiology, but you get it as a sort of side issue. They teach you how to diagnose a particular malformation, and they tell you what the treatment is. And they say to you, by the way, you treat them because, and then they tell you the pathophysiology. Because if you don't, this, that, and the other happens. So it's an afterthought, you know? And if you take textbooks of surgery, doesn't matter if it's acquired or congenital, if you take each chapter that deals with whichever condition it is, there is usually a section on pathophysiology of that condition. It's usually 1 paragraph or 2. And it's an afterthought. So you learn it that way. And that's why it takes a long time, because eventually you learn it all. But you have to put it together, and it takes forever, and you get your knickers in a twist, and you spend a long time in a state of confusion. Whereas it need not be that way. That was my experience. That's what I lived through. That's what made me suffer. That's what made me want to remedy it for generations after myself, hoping that this would facilitate it for them, provided you're successful in convincing them, because a lot of people are not convinced. When I mention these things to many of my colleagues, they laugh. So, oh, pathophysiology. Oh, okay, leave that for cardiologists. Well, you know, one of the things that is one of the other things I've noticed about pediatric cardiac surgery is that the collaboration between different teams is so tight, so close, more so than I've seen in other fields. I mean, sure, in adult cardiac surgery, you have meetings with cardiologists, fine, yeah, but they're not that detailed. In pediatric cardiac surgery, the function of the cardiologist and the surgeon, they're inseparable. And I would extend it and include the anesthetists and the intensivists and the perfusionist. Our multidisciplinary meetings include all those people, and they all interact. It's a very, very team-intensive work, more so than I've seen in any other field. So when I talk about my team, I include all those people. And I call my team the Congenital Heart Disease Unit. I don't call it the Pediatric Cardiac Surgery Unit or the Pediatric Cardiology Unit or Service. No, I call it, this is our team. This is the unit. The Congenital Heart Disease Unit has many members in it. Each one does one aspect of it. One person does the diagnosis with echo. Another person does the catheter studies to measure the hemodynamics. Another person does the anesthesia. Another person does the perfusion. The perfusion for congenital heart disease is very different from the perfusion for acquired heart disease in adults. It's like two different worlds. You know, they have more differences than similarities. And it's very frustrating when you have adult perfusionists who think that they can come and do pediatrics by miniaturizing things. It is a really frustrating experience to have to deal with it. But, you know, then someone else in that same team does the operation. Someone else does the post-op. Someone else does the post-op echo. But these are all what I call them specialists in congenital heart disease, including the anesthetist. We are all in the same team. And if you don't treat it that way, you will suffer. Your patients will suffer. I mean, at Birmingham, you see this. I mean, I don't know what it's like now, but when I was there, it was totally like this. It was all one unit, and everyone was free to give their opinion, and discussions were open. You know, you go to other units when it's not like that, when you have a surgeon who might be a dictator, well, they do badly. They do badly. You need a team mentality because of these challenges, because of these difficulties. Probably historically in pediatric cardiac surgery, perhaps the best example of such a mentality was Aldo Castañeda. Aldo Castañeda was the chief of cardiac surgery at Boston Children's Hospital for 2 decades. I think he arrived in 1973, I think, and retired in 1993. And I don't think one can come up with a better example of team forming, of developing that mentality that everyone's in this together and everyone's in this because this is complex and everyone's opinion matters, master of it. Whether others can live up to those standards, well, probably not, but it's good to aspire to it. He was an example to us all. He passed away a few years ago, but he certainly set the bar very high. And he understood all of this. He knew that for this thing, this complex thing to hold together, you need that mentality. And the rest is right before your eyes. You know, all the things he put in place, all the people he trained, a lot of his philosophies are still guiding people. And it all goes back to the teamwork. And even this concept of trying to simplify things by focusing on processes rather than specific diseases, it also facilitates communication between all these team members. Because if you think of it purely in a structural format of the malformation, well, then that gets the cardiologists very excited because they do the echoes and the imaging and they love that. But an anesthetist won't care particularly because it doesn't affect them. It doesn't affect particularly the perfusionist. If you talk about the surgical technique of fixing it, you get the surgeons all excited, but no one else really cares. And if you want to talk about the post-op course, what it's likely to be and all of that, you get the intensivist very excited, but the anesthetist won't care, and the perfusionist will care less, and the surgeon says, oh, well, that's someone else's problem, you know. But if you talk about processes, that's one thing they all have in common. Doesn't matter if you're a surgeon or cardiologist, intensivist, anesthetist, perfusion, doesn't matter. The processes are there. They're looking at us right into the face. And that's what determines everything. So it helps hold the whole team together. We can take this back to what I was saying about Aldo Castaneda. I have never worked at Boston, but those who have tell me that they have a mentality of thinking about processes. What is likely to happen? Why is this? Why is that? And they get really deeply into it, and they have a very, very efficient system of training people. I suspect in great part is because of this. I'm certainly convinced by it and thoroughly recommend this approach. And I'm not just saying this because I've written a book on it, which you might think I have a bias because I want people to buy my book. Well, let me tell you something. I make no money from that book. Theoretically, I do, because when the book was coming out, I said to the publisher, I said, I don't want any money from it. You just charge. I want this book to be available to people. That means I want it to be cheap. People who buy it are surgical trainees. They're not, or trainees in general. They're not rich. They're all on a small salary. I want it to be accessible. So I opted for non-glossy paper to make it cheaper. Which was interesting because one of the criticisms on Amazon about my book was that it's not glossy. One person from Brazil, I think, said that I expected a book of this caliber to be at least on glossy paper. That was a very deliberate decision to make it cheaper. It's not hardback for the same reason. I wanted hardback would have made it like €3 more expensive, something like that. I said, well, let's cut that out. And I said, please don't pay me. I don't want a percentage to keep the cost down. They didn't accept that. The publisher, it was interesting, McGraw-Hill, you'd think McGraw-Hill is such a big publisher. It's the bigger than all of these things. You'd think they think nothing of it, but they said no. They said that it turns out that if I don't take any money, then from a fiscal point of view, this counts as though I've made a donation to them. And it creates a fiscal problem for them, which they can do without. They said, no, you must take a percentage. It's very small. I think for every book, what I get is, I don't even know. I've never collected any, but I think it may be in the order of €1 per book, something like that. I don't know. So I've never collected it. The book has sold quite a bit now, and those euros are accumulating in some box somewhere, I don't know, at the publisher. I've never actually said, okay, how much is there? Give it to me. I'm sure it amounts to not a huge amount, even if every person on the planet who does this specialty buys one, that amount will not make me retire. So I don't know. But that is to say, I have no financial interest in it at all. And that supposed nominal fee I receive, I've never collected. It's just accumulating somewhere. So what I'm saying is that I'm not trying to say you must go this way because I want to sell my book. I don't care about that. I care about selling my book because I don't want others to suffer like I did, like a lot of people did. I think it sort of explains the processes. It smooths the path. If you accept what I'm saying in terms of how important it is to understand those processes instead of starting with diseases, malformations, and then on a side learning its pathophysiology. If you accept what I say, that for me is a much better way of going about it, then yes, you'll enjoy my book. But if you don't agree, which a lot of people don't agree, well, then don't even look at my book. You just go and, there are plenty of books that describe all those pathologies. So there you go. That's why I'm enthusiastic about it. The other thing I've even mentioned to my publisher, I don't think they take me seriously, is that if someone photocopies my book and gives it to their friends, I will never sue anybody. Be my guest. Do whatever you want. Just read it, you know. I mean, there are countries that don't recognize copyright, you know. I think China is one of them. I think they don't recognize copyright. So if some Chinese person sees this book and likes it, it's okay, I'm going to take this and translate it into Chinese for the whole of China and sells it to everybody. Fine. Be my guest. I mean, my publisher gets upset when I say be my guest. I say, but I'm saying I have no interest in that. My interest is nerdy, shall we say. I just want to make people see this side of it, that it's an easy way to handle a very complex field. It's an easy way to make a very complex field much less complex. And that's all. I think I've talked a lot. You probably fall asleep. Maybe I should stop talking. And if anybody would like to ask me questions, I would be delighted to answer. There's a question: is there a new edition of my book in process? Yeah, it will come out in 2026, I hope, the third edition. So if you have not got my book, it's worth waiting for it. It's a better version. If you have got my book, don't bother buying the other one. I mean, it's better, but you know, if you've already spent the money on this one, this is good enough. Anyway, I'm here if anybody would like to ask me any question. I'll try and answer. I don't promise I know the answers.
Thank you so much. I mean, to be honest, just in 10 minutes, you made us understand ASD with pulmonary stenosis, Fallows, TGA. And that's just something that even on, you can spend a year in congenital, but unless you really, really get down to paying attention to these things, you don't really pick up. I think for me, I'm on the tail end of my year in Birmingham. And only now am I beginning to realize this is starting to make sense. Yesterday, we were talking about EDP, transpulmonary gradient, things that in the beginning of the year were just three-letter words that meant nothing to me.
Yeah.
But now, I think, especially reading your book, it's all starting to make sense, the big picture.
Well, you see how simple it is. At the end of the day, it's actually not very difficult, you know, but you have to know how to go about it. Because if you go about it the other way, you could get lost, you could drown. Whereas if you go the way I suggest, well, I suggest it because that's what rescued me. I was drowning. This is what rescued me. By approaching it that way is what pulled me out of drowning.
And I think a lot of people start out with that kind of physics type of mind where you want to just know the first principle and then try to apply it. But then with the speed of the information that you're supposed to take in, you get caught up in thinking, okay, I need to first learn what TGA is, then I need to learn what fallow is, then I need to learn what double switch is, then I need to learn about isomerism, this, that, and then you get fully overly immersed, shall I say.
Well, the thing is, that is the attitude that works, I would say, quite well with acquired heart disease. And that's how we are first brought up. We all brought up learning acquired disease in general, all diseases. We all learn about pneumonia way before we learn about congenital lung anomalies. You know, we learn about osteoarthritis way before we learn about congenital skeletal malformations. You know, same applies across specialties, you know, so it works. It works because the basic structure is normal and things just become less and less efficient with disease. But those rules don't apply to congenital disease. All the rules change. Everything is just, it's almost like each patient has a different physiology, you know? So unless you understand processes, you can get lost very easily, very easily. So this is why I recommend this approach.
I
Some
guess
people
one of the
in Birmingham, they believe it. Miss Khan, Natasha Khan really likes it. Tim Jones really likes it. David Barron really likes it. But I am not sure if they really like it because they really like me, because they know me and, and they've trained me, I don't know. But there are other people who have not been convinced. They think that
Mm,
you want to be a good surgeon, you need to learn how to cut and sew. Well, cut and sew is easy. It's a question of repetition until it sinks in, and we all end up doing it well. Some people who have talent, what does that mean, talent? It means they learn it sooner than the other guy who has less talent. But at the end, if you keep doing it long enough, we all get there. A very
mm.
talented guy has learned it after 50 cases. A less talented guy has learned it after 500 cases. But eventually, we all get there. So that's not the challenge, for me.
I remember my one of my first experiences in cardiac surgery. I asked one of the registrars, "What do you think about, apprenticeships where you just work, you work, and you work, you just learn how to do the technique?" He sat me down and he told me, "You can do an apprenticeship in surgery, just spend all your time in surgery, but that won't make you a good surgeon." And that lesson I keep seeing repeated throughout.
Yeah, yeah. I mean, it's there's so much to surgery, so much beyond just operating. If you
Mhm,
think of the percentage of the time that a surgeon operates, that's not most the highest percentage of his workload. You know, the highest percentage of his workload are all the decisions that he has to make. They have to make. Um, um, it's operating is very overrated in terms of physical operating. It's um, what's even worse, speed in operating is very overrated. And it goes back to history because throughout history, there was no anesthesia. Anesthesia is less than 200 years old. So unless you were quick, you couldn't operate. And so for thousands of years, a good surgeon was a fast surgeon. Now, modern anesthesia has eliminated that need, but for some reason, that culture has stuck and is still there. And surgeons still show off to each other because of how short their cross clamp time was or something silly like that. I mean, I was the same. I'm no angel, but I eventually realized that the best myocardial protection is a good correction, not how short it was. Within a good correction, if you do it in a shorter time, better. Okay. But don't compromise the quality of your work so that the time is shorter. And to this day, I still see people doing that. Surgery is complex. It's not a single facet discipline. There are multiple facets, and surgical technique is one of them, but understanding what you're doing is also another one. And dealing with the science side of it and research is another one. There's a big administrative side is part of it. Audit is a big part of it. These are all important building blocks of making a good surgeon. And people, when they say surgeon, just think of holding a needle hole in your hand and stitching. Sure, yeah, that's important, but that's, in my experience, that's been the easiest part of surgery to learn. It's overrated, in my opinion.
I think someone's put in a question in the chat. Do you have any advice for young surgeons who want to work in this field? We're told it's a long road, that there's no work, and that there are fewer and fewer patients.
Well, that is true. Not just pediatric cardiac surgery, but cardiac surgery in general is becoming a specialty of leftovers. So in adult cardiac surgery, for example, you get to operate the things that the cardiologist cannot do with a catheter. The leftovers come to you. And what they do with the catheter is increasing all the time. Aortic valves have become revolutionized with that sort of thing. Now they're taking bigger and bigger chunks of other valves and the pulmonary valve prosthesis put in by catheter. All of these things, they are taking bigger and bigger bites out of cardiac surgery. So when we operate, it's because the cardiologist couldn't do it with a catheter, but catheter techniques are evolving. So they do more and more. So it becomes a leftover specialty. In pediatrics, even more so, because in pediatrics, prenatal diagnosis and termination of pregnancy has really had a very big impact. And catheter techniques are evolving rapidly, and they do more and more. So again, in pediatrics, every time I operate, it's because the decision was made not to abort the pregnancy, which happens. A lot of people terminate the pregnancy when they find out that there's something wrong with the fetus. We are living in the age of people wanting perfection. So, they terminate some of the things that are relatively easily correctable. They still terminate them. And because it's the culture the world is going towards. I'm saying that without any judgment. I don't know what I would do if that was my baby. I don't know. But that is a direction that is very, very obvious. And for example, when I first became a consultant, I was doing one switch a month, pretty much. 12 a year, yeah, something like that. And I was doing at that time something like 6 or 7 Norwoods a year. Now I do 2 switches a year and maybe 1 Norwood a year because they get aborted, So that goes, and then those that do survive, are born, then the cardiologist put their hands on, and more catheter techniques. Again, to cut a long story short, by the time they get to the surgeon, they're the leftovers from not abortion and the cardiologist not being able to deal with it otherwise. So it's becoming a specialty of leftovers, and it's shrinking. But people still need pediatric cardiac surgeons because those leftovers still deserve treatment. However, it does affect the number of people needed for it. And that's where career prospects become problematic because, well, how many people do you need if so many of them are being aborted? When instead of 12 switches, I do 2 a year. How many surgeons do you need for that? Norwoods, I do 1 a year. I used to do 6 or 7 a year. What do you do? So it's not an expanding, it's not a booming specialty at all. It's a shrinking specialty for now, but it's still very exciting. I don't regret being in it. I love it. But I do appreciate how hard it is. Hell, I left England because there were no jobs. I left England against my wishes. I wish I'd stayed in England. Well, I'm not unhappy. I'm delighted I've gone. But at the time when I left, it was against my wishes. Things turned out very well for me, but I did not know that at the time.
Thank you.
Depressed you enough?
No, I mean, it's very true. I think all of us do think about the bottleneck. And I mean, you mentioned about the numbers, and I think to an extent it's still true. But yeah, I think someone else has asked something as well. Oh, they can't find your book in Turkey.
Oh, well, you can get it off Amazon, or you can get it off the publisher. I forget the website of the publisher. If someone wants to drop me a line, I can give them the website of the publisher. Or if you want, I send it to you and you can distribute it to people in your association if they don't have access to Amazon. But I repeat, wait till the 3rd edition comes out. Wait till 2020, unless you're in a rush, But the 3rd edition is significantly improved, in my opinion. But yeah, I can give you the website of the where the book is actually printed. That way you can bypass Amazon. But if you have
Okay.
access to Amazon, that's easy, you know.
Perfect.
And don't criticize
Amazing.
the fact that it's not going to be glossy. It won't be glossy. And it won't be hard.
You should have an optional extras one for the glossy paper, the
Yeah,
hardcover,
just jacks up the price.
yeah,
Yeah,
and a signed copy as well.
sign
Yeah,
that's free. Signing is free.
that's it.
Yeah, yeah,
I
yeah.
guess I had a question in general, which is how did you learn about conduction? Because that's something that I found has been the most challenging concept to grasp because there's not much in terms of a consolidated resource which tells you or teaches you how to think about conduction. For example, where's the conduction in a VSD? Everyone tells you, oh, it moves posteriorly, but then you get to the places where the rules start to break down. You have the switches with the VSD, or you've got the isomerism. What was your way
Well, I
around?
did my doctoral thesis in cardiac morphology precisely because of these things. I needed to learn exactly these things, and the way to do them is to hold those hearts in your hand and examine them. And they are now well published. They are published by Yen Ho, Bob Anderson, um, um, and others. The information is available. I have not covered that in my book because that's technical. My book is Pathophysiology, but I suspect in textbooks of surgery, you probably find that information. If not in anatomy textbooks or publications, if you look at Bob Anderson or Yen Ho, or they're probably co-authors, in fact, you will find that. Essentially, it comes down to the junction of the interatrial septum and the interventricular septum. Um, and uh,
Crooks.
and that's where the two meet, where the muscular part of the two meet, that's where the atrioventricular node is. Doesn't matter how complex the heart is. Doesn't matter
Yeah.
if it's completely scrambled. You look at the ventricular muscular septum and you look at the atrial septum, the triangle of Koch, you look at that and you see where the two meet. Wherever that is, doesn't matter how abnormal the heart is, doesn't matter if it's upside down, inside out, twisted. That point of junction is where the atrioventricular node is, in a very simplistic sense. Yeah.
It's usually they say the crux of the heart. That's where you'll find the AV node or the conduction.
Well, not if,
Yes.
again, you're taking a diagnosis and working
Yeah.
backwards. No, take the
Yeah.
process, that would not happen if you had, for example, double discordance. If you have a heart
Mm.
with double discordance, the node cannot be there because at that point, the atrial septum does not come in contact with the ventricular septum. So it cannot be there, except if there's pulmonary atresia. If there's
Yeah.
atresia with that
The
malformation,
angle
and they
narrows.
become aligned, and that's where it is. I've actually
Mhm.
published that. It's in, I forget which journal, but if you put my name, um, I think it was in Annals of Thoracic Surgery in 2002, maybe. I'm not sure.
Mm.
But if you put conduction tissue, Hosseinpour, Yen Ho, it will come up. And it
Oh,
explains.
I read this paper yesterday actually because I was looking at
There,
conduction for double discordance.
well, there you go. So it was a trick question then. You
Yeah.
know, if I've read my own paper or not.
No, I mean I think it's very interesting to see it, but then it's very hard to wrap your head around sometimes just to understand when the heart starts to scramble, when you have
Yeah,
double discordance with atresia, without
yeah,
atresia, and then
yeah. Well, that's the thing.
yeah.
If you look at the two septa,
Hmm.
you know, and if they're separated because of the complexity of the malformation, the point of contact between the muscular part of the ventricular septum and the atrial septum, that's where you find the node.
Hmm.
Doesn't matter how distorted the heart is.
Yeah.
Yeah,
Ah,
there you go.
amazing. Thank you.
Okay.
I feel like I've learned more in the last 1 hour than I have in the last couple of years even.
Well, that's too much honor. You're giving me too much honor. just keep it simple and you'll go far. I mean, that's the whole point. I mean, my entire book is about simplifying it, you know. I mean, it's a big thing to say when the book is 600 pages, but nevertheless, without it, it'd be like 6,000 pages.